Good afternoon, everyone. Welcome to the first of the restarted Mile High Healthcare Analytics webinar series. We took several months off. We missed everybody, but we've been awash in data from health plans and providers, and a lot of those experiences, coupled with years before that, have been integrated into this presentation. So I'd like to get started. Okay. So today we're going to talk about the Johns Hopkins ACG system, which I have a lot of direct experience with. So I was a part of the ACG development team for about 14 years, from 1991 to 2005. Several of my colleagues, most of the people that I work with are still there. Several of them are on this call or slated to be on this call, so I have to say good nice things about them, which I will anyway. But I was involved with the attempted development of a Medicare ACG system, Medicare risk adjustment system, using the ACG system. We also implemented ACGs in the state of Maryland and Minnesota's Medicaid programs. Medicaid is the kind of the father of risk adjustment, despite many people believing that Medicare really got the ball rolling when they didn't. Since that time, I've been spending most of it designing and deploying and analyzing side-by-side risk adjustment and quality measurement data, and very recently working with some of our clients who are using ACGs for ACO shared settlements, and also for other population health applications. So today's agenda, we're going to talk about, I've rebranded our 30 days and 30 seconds to people who used to come to our webinars. I just got tired of the phrase. So now we've rebranded it as Mile High Musings. We're going to then go over the selected features of the Johns Hopkins ACG system. There's no way that in less than an hour we can cover everything, so I've selected some of the components to be discussed. We're going to have a very brief introduction to the Health Partners Total Cost of Care algorithm. Since as I was designing this presentation, it did go long, so I've had to cut out some things at the end, and we'll just get back to that in a future thing, and then a future webinar. And then lastly, how to manage data so population health analytics becomes a reality, because regardless of which population health platform you use, or platforms, absent good encounter data, or good data in general, and provider data, it will not be a reality. So we'll go through some of those issues. So the Mile High Musings, I mean, obviously I haven't done a webinar in about 9 months, and I think a few things have happened over the 9-month period. So I've just arbitrarily selected a couple of things, because if I really wanted to talk about everything that's happened in 9 months, we'd be here for 4 hours. So one of the things that I want to point out to everybody, there was a really interesting study recently published suggesting that all but 3% of ER encounters, emergency room encounters, are not avoidable. Now, it is true that the group that released the study is the American College of Emergency Physicians, so you can take those conclusions with a grain of salt. On the flip side, it was a methodologically reasonable study relying on federal surveys and data collection over a long period of time. So the debate as to what proportion of emergency room encounters can be delivered in alternative settings is still a question. Certainly, as we've discussed, as everybody discusses, and certainly is published about healthcare reform and healthcare cost containment, everybody always points to prescription drug prices, and that debate is likely to be with us for a long time. In a recent study published in JAMA Internal Medicine, I think it was last week, a pair of cancer physicians, oncologists, computed or estimated from public SEC filings that drugs cost about $678 million to develop. That includes the cost of drugs that don't make it, because the majority of drugs that go into clinical trials never get approved. In contrast, the industry pharma, relying on a tough study asserts that the average drug cost is $2.7 billion for development. The Tufts study doesn't release any information. They were provided information about 10 drugs from the pharmaceutical industry, and it's a big secret as to what they analyzed, whereas the recent publication, JAMA Internal Medicine, actually used public data. So those are both, in my opinion, interesting reads. So the other issue, again, as we hopefully move out of the rhetoric of making insurance cheaper, we have to grapple with the fact that provider concentration is really a key driver of high healthcare costs. And there was just a study released that as of 2016, 90% of MSAs were highly concentrated for hospitals, 65% for specialists, 39% for primary care physicians, and 57% for insurers. And I see that in all the markets that I go to, and just the dramatic changes in how physicians and hospitals are organized, and that just leads to all kinds of market failures. On the risk adjustment or exchange front, the Court of Federal Claims, which is the court, it's a special court that adjudicates claims when the government hasn't kept a promise or has breached a contract. And the judges in the Court of Federal Claims are trying to have it both ways on the several lawsuits related to the risk corridor payments for the exchanges, for the issuers. So one judge on the Court of Federal Claims ruled in favor of both Molina and Moda, said that that the government made a promise to pay make the risk corridor payments. But a different judge ruled against the co-op in Maine, and yet another judge dismissed the case filed by Land O'Lincoln, which is on appeal. So even though we're talking, obviously, right now, there's a lot of press about what's going to happen to the CSRs. The issue of risk corridor payments and reinsurance have not gone away, either prospectively or in the past, and they're going to be around for a while as these cases and others get litigated, up the food chain. And along the lines of reinsurance and risk corridor payments, there was an April study that indicated that actually the 3 Rs had the desired effect on the issuers. That before the 3R payments, issuers basically, as it says, were losing their shirts, and afterwards there was a modest profit. Again, that's going to be subject to debate, but I think it leads one to conclude that there has to be a way to finance healthcare of very, very sick people by whatever means, and that's all I'll say on that. Okay, so moving on to the ACG system. So the ACG system is a very, very old system in the sense that when it began development, it's based on research that was conducted initially back in the late 70s, early 1980s by the late Dr. Barbara Starfield. And I won't read what's on the slide, but it's basically her work around the notion of comorbidity or multimorbidity. The two terms they have different meanings, but they're often used interchangeably. ACGs really have their conceptual birth back in certainly in the 80s and very, very early 90s. All the work was done, at least back then, at the Johns Hopkins Bloomberg School of Public Health. The principal architect of the ACG system, Professor Jonathan Waters, I consider him one of my mentors. I've spent a lot of time with him, and I think the work that the folks at Hopkins have done and now being done, frankly, all around the world is quite fascinating and extremely useful. I think the most important, on this slide is the first quote: people should be characterized by their morbidity burden, and more importantly, by the patterns of morbidity that they experience with time. And that's really the key essence of what makes, the ACG system different from other risk adjustment methodologies, solely risk adjustment methodologies like HCCs, like CDPS, and so forth. And then there are, several other systems that, that are similar to ACG in terms of the design principles, the CRG model from 3M, but I don't believe any other system has the breadth that the ACG system has. So in terms of commercial development, the ACGs were the first commercially available risk adjustment system back, I think it was 92, maybe it was 91. I came around in 91. You know, I often think back to how long ago that was, and I realized that I first learned about ACGs at a conference, and when I got back from the conference, living in Baltimore at the time, I took out my Smith Corona electric typewriter and typed a letter on paper, put it in an envelope, addressed it to Professor Weiner, and mailed it. It was a long time ago. And the rest is kind of history. I joined the team as a consultant and was there for about 14 years at various levels. So ACGs were the first implemented in Maryland Medicaid program in 1997 or 98. Currently, 3 states are still using ACGs for payment to the Maryland to the Medicaid managed care organizations. That's Maryland, Louisiana, and Tennessee. As I indicated at the beginning, for about 6 years, we squared off against the Boston University and Brandeis team to develop and implement a comprehensive risk adjustment system for Medicare Advantage, and it should be no surprise to anybody that we lost that competition. But now, really since 2000, ACGs have become a suite of many tools and are certainly not a risk adjustment system, or not just a risk adjustment system. And they're used, you know, all over the world. I have 18 countries. That's probably too low, but so we'll say at least 18 countries. So in terms of how they're different, most risk adjustment models in general are geared to generating the most accurate payment for a particular group or program. So, you know, the CMS HCCs for Medicare Advantage, the HHS HCCs for the exchanges, CDPS and CDPS RX is the most popular of the risk adjustment methodologies in Medicaid. And these systems all work, in my opinion, they work pretty well. They work well for what their intended use is, which is to generate reasonably accurate, or as accurate as possible, payments and capitation rates. But the ACGs are built for a completely different purpose. You know, I don't see the systems as interchangeable. Obviously, as I just said, ACGs are being used for plan payment, but in Medicaid and in only 3 states. Most of the systems that are out there are focused on plan payment, and they do a reasonably good job. They do that, as most people know, if you work in a risk adjustment system, is they have series of categories, whether they're called HCCs or CDPS categories, and for a list of diseases, and they assign a weight to those, and you add them up and you get a payment weight. The ACGs work very different. They rely on a pattern of morbidity to assign people to a single mutually exclusive category for a defined period of time, typically a year. So everybody gets into one and only one ACG, which is different from the CMS HCC model, where there's a score. Everybody has a risk score, but it's comprised of the addition of a whole series of disease-specific and age and sex generated developed weights or payments. So this is just briefly. I mean, again, in terms of, you know, all risk adjustment or population health systems at least start out the same way. You know, there's all these healthcare encounters on the left side of the screen, and those generate diagnosis codes, currently ICD-10. And then in the case of ACGs, they get mapped to something, and I'll explain this more in a moment. It's called a series of morbidity groups, which are called ADGs, and there are 32 of them. And in some respects, they look, at least on the outside, like HCCs, but they're really not, because they're constructed not based on disease, but they can be mistaken for that. And then from there, the ACGs, as I just indicated, everybody gets assigned to one and only one ACG, so that's the baskets on the right-hand side. So let's talk about some of the building blocks. How do you get to an ACG? So there are these things, these categories called aggregated diagnostic categories, or ADGs, and these classify ICD-10 diagnoses into a limited number of clinically meaningful but not disease-specific morbidity groups. So some of the names, you can see some of the categories on the right-hand side of the screen, things like chronic medical stable, likely to recur, psychosocial, and so forth. So they're not like, I mean, again, on the outside, maybe people say, well, there's discrete categories, they must be like HCCs, but they are really not. And the criteria that are used to assign diagnosis codes to an ADG are based on, are shown at the bottom, and they're based on the duration, severity, diagnostic certainty, the etiology, the cause of the disease or condition, and the expected need for specialty care. So, again, it's not just putting diseases into buckets. There are 32 ADGs, and those form the building blocks of the ACG system. So this slide talks about, again, it illustrates, and you might have to stare at it for a while. You can, download our slide deck, and it indicates the kind of the criteria that are used to put people into the ACG. So we have our non-users on the left-hand side. We have our single morbidity categories. What's really interesting, and we'll talk more about this later, is that there are the ACG typology. Really, it was developed back in the 70s or 80s, but it hasn't changed. That speaks, I think, volumes to the stability and of the approach. So single morbidity categories like acute minor, acute major are for people that have one more morbidity. And then we have commonly occurring morbidity combinations, things like acute minor and acute major, and we'll show you some examples. And then there are the complex morbidity combinations, and then pregnant women and infants have their own decision tree. So this is sort of what it looks like. And again, I'm skipping over. There's a lot of things I've left out, and that's by design because we really can't get into all of the nuances of how you get from a healthcare encounter or a diagnosis code to an ACG. So I'm just giving you sort of points along the way that have been selected. But basically, it's at the end of the process, ACGs are formed by way of a decision tree. So in effect, what is done is categories are split into terminal categories known as ACGs, and the goal is to get categories that are where all of the people inside the category are more similar to each other and less similar to people in another category. So you're trying to minimize within group variance and maximize across group variance. And that's how you get the ACGs. There are 93 ACGs. Well, there's actually 105, but a lot of those are for pregnancy and infants. So for the most part, there are a total of 93 ACGs in use. I wanted to briefly show you that, and I talked about this 2 slides ago. When you get into the complex morbidity combinations, we don't have specific, diseases or specific ADGs that are put together. We have just counts of ADGs, and that's what this decision tree is. This is for all the very, very sick people. They get their own decision tree, and it's divided up. The categories are formed by counts of ADGs. There's something called major ADGs, which are a subset of the ADGs. They are, as the name implies, major ADGs. And also at times age is used, and in some cases gender, to further split the categories to end up with a stable set of cells, actuarial cells, that are different from another, sufficiently statistically different from each other. And this typology has been around for a long, long time, which again, as I said a moment ago, really speaks to the stability of the system and to the conceptual underpinnings that, I mean, way back when in the early 90s, we didn't have a pregnancy tree or an infant tree. Those were added later, but the main ACG decision tree has really been around for a long, long time and continues to perform very well. There are also, because there are 93 ACGs, there's a need at times to collapse them into smaller numbers of groups is something called RUBs, which are resource utilization bands. There are 5 of them. And what this slide is showing you is that ACGs can be used, or it's less granular aggregates. It can be used to characterize morbidity in the past or in the future. And again, this system works both prospectively, which is in the future, and works retrospectively, which is in the past. But there's more to the system. And again, so there's even an RX to morbidity category grouper. This was created towards the end of my tenure, around 2005, I think. I don't know, don't remember when they went live with it, but something called the RxMGs, which are groupings of NDC and some HCPCS drug codes, the J codes, that are based on active ingredient and route of administration combinations that are similar in terms of morbidity, duration, stability, and therapeutic goal. And you can see some examples of corticosteroids on the right-hand side and how they're divided up into various RxMGs. So the development of RxMGs really took a lot of work over several years, and a lot of thought went into it. It's not just, it does give you the ability to identify, in some cases, specific diseases, but in other cases, it gives you classes of diseases or overall therapeutic categories and such. So like, as the slide indicates, the corticosteroids treat so many different diseases, it would be very, very difficult to, and basically arbitrary, to assign NDC codes for corticosteroids to a particular disease because they're used everywhere. So as you can see, the assignments of these drugs go to broader categories than to specific diseases. In contrast, if you're categorizing insulin or a lot of the diabetic oral hypoglycemics, those usually pretty cleanly map to a diabetes category. So the RxMGs are interesting both for the disease specificity of some of the codes and the more condition specificity for medications that do not map to specific diseases. But what happens if you want to, some people say, but I just want to build a registry of diseases. Okay, I want something that looks like HCCs because I just need to know who's a diabetic, who's had a stroke, who's had an MI, and whatever. Well, they have that. That's also part of the system, and that's why it's a system. So the expanded diagnosis clusters were added back in the late 90s, I think. These are a series of 282 discrete categories, and they look like HCCs or CDPS because they are individual categories. So a person can have as few as none and as many as 282 EDC categories based on diseases they have, and they're achieved by mapping diagnosis codes, not unlike other models. The major difference here is the fact that most of the risk adjustment models, actually all of the risk adjustment models that are used for plan payment operate with a selected list of mostly chronic conditions. That's not always true, but mostly chronic conditions. So in the CMS HCC model for Medicare Advantage, there's about just over 8,000 ICD-10 codes out of a total of 68,000 ICD-10 diagnosis codes. In contrast, the ACG system groups the overwhelming majority of all ICD-10 codes. So you don't just have people that are chronically ill. You have chronic illness, acute illness, and a whole range of other things, and they can be represented through the EDCs, and that can be used to create a registry if you just need to know who's got what disease and so forth. And the beauty of that is that you can then combine it with the ACG-derived morbidity scores or the RxMG-derived morbidity scores and get insight into how sick the the people are in a particular registry. That's the problem of just working with the disease-specific registry, is that it's just people, again, consistent with the principle behind ACGs of multimorbidity. Most people don't have one disease, particularly as you get older. So the EDCs used in conjunction with other components of the ACG system can be used to shed further light. Okay, so that was the very, very brief overview of the ACGs. I did not go into every component, and I did not explain entirely how you get from a diagnosis code to an ACG category. And again, as I said earlier, that was by design, because we can't do that in less than an hour. And now I want to get to really what is really the topic of this webinar, and to illustrate a selected set of features, of things you can do with the ACG system, some of which you can't do with other systems, because the ACGs really aren't just a risk adjustment system. They've really become a whole, as I said at the beginning, a whole suite of tools. So we're going to talk about risk scores that describe or predict cost, hospitalization risk models, utilization and resource use markers, care coordination markers, and pharmacy adherence for effective care, which is actually my favorite. So this is the ACGs, like a lot of the black box predictive modeling algorithms, can produce this, predictions that lots of other entities produce, things about probability of hospital admission. In the ACG system, it's probability of hospital admission at 6 months and 12 months, probability of ICU admission, probability of any admission, probability of being high cost, and so forth. There's several, at least a dozen different probability measures around utilization, and some of them are shown on the left-hand side of the slide. One of the things that's interesting is that because the ACG system is developed and is and owned by a public health school, while the whole system isn't open source, a lot of it is out there for people to understand how it works. And that's really been one of my frustrations, as I see vendors who claim to have secret black box algorithms about how they get from, how they can predict people who are going to be hospitalized and so forth. And the ACG system, because of who is behind it, or who and what is behind it, is able, I think, to be above the fray, so to speak. On the right-hand side of the screen, I just pulled up from the software. So there's on the top, the orange chart actually shows probability of hospital admission, and it shows that there's 672. 3.52% of this entire population has at least a 40% chance of being hospitalized within 6 months. On the bottom, we have various utilization markers, which show you a rate. Usually, most of them are a rate per thousand, and then there's a reference rate derived from the ACG system's internal reference data. Another good thing about the system is that you can calibrate it to your own set of weights, and that's something that I actually advocate, because at least right now the reference rates inside of the ACG system are based on ICD-9 codes. I assume in the not too distant future ICD-10 will be used. So I advocate, and we're doing that for one of our projects where we're recalibrating the system to use local data. And updating it to ICD-10 and so forth. So that's just an important, feature of the system. So, on the bottom there are just a handful. Bottom right, there are a handful of conditions that the system identifies: patients with psychotherapy services, cancer treatment, dialysis. There's a few more. I actually cut them off, but you can get a sense of, how many visits you have per 1,000, how many days, and inpatient days, and so forth. So my favorite part, actually, I thought it was the last one, but okay, it's out of my list was out of order. So moving on beyond the typical, what's going to happen to you next month or 6 months from now kind of application, which is, out there. There are lots and lots of groups that do that. Not all of them do it very well, but some do. Is the ability to assess compliance with treatment regimens. So what the developers have done is they've identified 17 conditions, most of which are chronic, and they are also treated with medication. I color the ones red that are common conditions that Medicare Advantage and Medicaid plans need to monitor, either for risk score purposes or for quality improvement. So things like Parkinson's disease, rheumatoid arthritis, schizophrenia, seizure disorders, and so forth, that are part of they're either a part of payment systems or they're part of quality measurement systems. But there are 17 of these conditions, and what you can do with them, is that the software outputs five metrics about each of the 17. I'm actually going to go to the next slide because I really want to talk about this. It basically tells you whether there are treatment gaps and how many there are at the member level, and then it identifies people who are not, for which there's no evidence of treatment in the data that was submitted with the designated class of pharmaceuticals. So you can use this system to identify people who are not being treated or are not taking their medication properly to be treated for a particular disease. And now I go back to this slide, and there are several measures of medication compliance. And there are 3 right here: the medication possession ratio, the proportion of days covered, which is used by NCQA for its quality measures. PDC is kind of the linchpin of all of the Part D medication adherence measures. And then there's some more esoteric measure, the continuous single interval measure. And you can look at the slide deck and read what these mean. But I think what's really valuable about this is that you can identify people who, as I said, are not refilling, because you really don't know if they're taking it or not, but it's certainly based on the assumption that the filling of a prescription represents the use of that drug. That's what these different metrics will tell you. And then again, I think it's very, very powerful if you can identify numbers of gaps, who's not being treated, and target those people for interventions. That's really, I think, a tremendous benefit. Another area is the ACG coordination measure, or measures. So there are 5 outputs from the system that are tied to particular providers that service the members. So there is the majority source of care, which I typically have always called the predominant provider, who's actually making decisions on behalf of the member. Most of the time it's the PCP, but not always. A lot of times you have specialists that have become the majority source of care provider, or maybe there's more than one majority source of care provider. So the data is analyzed and it identifies who is providing the majority of the care, and actually the definitions are incorporated into the ACG documentation, so you really can understand it's not black box. You can understand how people get into what category, and you can also change the various cut points. So there's also unique provider count, specialty count, was a generalist seen, and the management visit count, E&M visit count, and those are all put together into what's called a coordination measure, and those 5 measures from the last slide are then combined, and people are assigned to either having unlikely coordination issues, possible coordination issues, and likely coordination issues. And as you can see from the percentages, the overwhelming majority of people are in the unlikely category, and the remainder, which is about little less than 0.75%, are in the other two categories. From a study, you can see the dramatic differences in costs, in median total expenditures, year 1 and year 2. So the blue bars are year 1, the red bars are year 2, and the very small number of people who have likely coordination issues, use substantially more resources than the folks in the unlikely coordination issue category. So again, the system can be used to target people who are not utilizing the provider network in a way that is going to minimize expenditures. And again, as a vehicle for promoting efficient use of healthcare resources, this really is quite useful. One of the other things, and again, speaking to the sign of openness of the system, I actually was looking at a paper from a presentation from South Africa in which the folks used the ACG coordination issues, but they didn't work for them, so they actually recalibrated them using different cut points for majority source of care and unique provider count and so forth, and made them work for them. So again, you have that flexibility, which again is very, very valuable. You're not stuck with one particular black box algorithm where people get assigned and you have no idea how they get assigned to a particular category. I think I'm out of order. Hang on. Okay, I think I lost the slide. I'm sorry. So now I want to, I've used about 40 minutes to give you a very, very high-level overview of how the ACGs, of the components of the ACGs, and again, I've admittedly cherry-picked the components to show you things that I thought were more interesting, or to give you a basic understanding of how the assignment process works. I haven't told you everything, but if you're interested, there certainly are plenty of ways to learn more. So now I want to use the remaining time to talk about applying a system like the Johns Hopkins ACGs to population health, and then I'm going to segue into talking about data issues, because if you can't do data, then you can't do any of this stuff. So I think most people would agree that population health represents the most important driver of cost containment. It's not possible to lower insurance premiums until the underlying costs that comprise those premiums are managed, despite what has been all over the press for the better part of a year, or maybe it's the better part of 8 years, but certainly the better part of the last year, is a claim that insurance premiums need to be brought down. And while it's of course true, one is not going to reduce insurance premiums until you make the underlying costs of the healthcare cheaper, either cheaper at the unit cost level, but population health doesn't seek to impact unit costs, but at the person level by way of more efficient, less care, more appropriate care, and so forth. Developing value-based care paradigms is not easy. It's very important to not lose sight of the fact that many will be tested and many of those will fail. Ultimately, some value-based programs will succeed. I think one good example is the Medicare Shared Savings ACOs, which did very, very poorly for the first 4 years, have started to turn the corner, and although it is still true that the majority of the MSSP, Medicare Shared Savings Programs, ACOs, that have gotten shared savings are a small subset of all of the ACOs that are in the program. But it does indicate that over time, some of the provider groups that will engage in the ACO program will learn how to turn it to their advantage and earn shared savings. It is true that in the MSSP program, none of the ACOs are taking downside risk. It was envisioned originally when the Affordable Care Act was passed that ACOs would take downside risk, I believe, in year 3, and now they get at least 6 years where they have no downside risk before they're going to be forced, at least in theory, to accept some downside risk. So right now it's all upside gain. That being said, there are some successes, and there have been successes in some other various value-based payment demonstrations. As I said, not all of them will be successful, and that's just the way it works. There's not going to be a magic bullet on how to implement population health in your health plan. Okay, there's no one vendor, there's no one technique. It's not just like you know, the old bat computer from the original Batman of the 1960s, where they asked it a question, a piece of paper came out, and that was the answer. It doesn't work that way, as comforting as that might otherwise be. So I want to spend that, you know, change my kind of attitude a bit, and usually when you do a presentation, you try to end on a positive note, and I will end up on a positive, end this webinar on a positive note, but I do want to spend a few minutes being, you know, Debbie Downer or Bob Bummer or whatever, and really make some comments about encounter data and why, and demonstrate why that if you can't, you know, create a viable encounter data, then you really can't do population health. And what's really important is the distinction, a key distinction between using, let's just say, ACGs for straight risk adjustment for planned payment versus using it in a more population health mode, is that when you're doing, you know, when you're generating payments or generating capitation rates, you're generating rates for a group of people, usually a large group. And therefore, if you make a mistake or if there is some error in the weights, the impact on the group will be relatively small. In contrast, when you're using these, you know, the ACGs or other systems to predict who's going to be admitted to the hospital, who has a coordination issue, you know, who's not adherent to their treatment regimen, you're focusing on one person or a very, very small subset of people. And therefore, if the data is wrong, you're going to be reaching out to the wrong person, proposing interventions to the wrong person, and so it's really essential when as we go down this value-based payment path, to make sure that the data is complete and accurate. And you know, while it shouldn't really be, quote, rocket science, for a lot of health plans, they do really struggle with it. So, you know, population health is going to be a lot harder than Medicare Advantage risk adjustment or even exchange risk adjustment or STARS. And what I would say, and a lot of the plans we talk to and a lot of our clients are struggling with EDPS data submissions or 5010 data submissions in the exchanges. And if you're continuing to struggle with, you know, accurate data and accurate risk scores, then you're going to be in for a wild ride when it comes to population health. Your data really needs to be pristine. So let's, you know, from the C-suite's perspective, I think there's really a key question that has to be asked, and unfortunately is often not asked, and that is, does the data in the data warehouse represent every service that has been rendered to every member who is enrolled in the health plan? Most of the plans and provider groups that we deal with, you know, focus on the proportion of claims that get submitted to and accepted by the government entity, whether it's CMS or state or clearinghouse in certainly employer-sponsored health insurance, and they declare success if, you know, the majority or if an acceptable ratio of claims are submitted. This really is the wrong metric, in my opinion. The right metric that plans should be looking at is what proportion of all the services that were rendered to our members got submitted and accepted by the entity that processes the claims. And our work with a lot of plans indicates that Plans are leaving anywhere from 3 to 5% of premium revenue on the table, just because data is getting lost in the pipeline. And that's really all I'll say about that. We can talk about. I'm giving a talk in Scottsdale at the Rise West conference on Monday, which I'm going into this whole issue of reconciliation a lot deeper than I will today. But missing data also means lower quality scores, and it's really important. Although this isn't true in Medicare Advantage, but a lot of state Medicaid programs are turning to sanctions for incomplete encounter data. So the state of Washington withholds 5% of Medicaid premiums, MCO premiums, pending reconciliation of the submitted encounter data with the plan's financials. And Missouri is doing it, and there's a bunch of other states that are all mandating in some form or fashion with modest or even not so modest sanctions that plans need to be submitting complete data, not just accurate of the data you get in, but is it really complete? So in terms of data requirements for population health, it really gets to, it's a broader list. Not only do you have to do encounter data well, you also need to focus on particular data elements and ensure that they are accurate and complete. And I'll talk for the next couple of minutes on different categories of data that are germane to population health. So on my list here, we've got diagnosis codes, which is, most people who are in this business have been working with for quite a long time, although I'll talk in a moment. I see still tremendous high frequency of errors. National provider IDs, when I showed you a few minutes ago, the coordination issue metrics in the ACG grouper and the various majority social care metrics. If you don't have good provider IDs, you won't get accurate information. If you don't have the specialties and can't get the specialties accurate, you'll have problems. Unit costs, paid and allowed, are really an important component of being able to do this. Certainly procedure codes, and then we get into the various inpatient or institutional components like the UB04 revenue codes, the UB04 bill types, and lastly DRG. So I'm going to talk more about these in a bit of detail. First, I just want to talk about patient identifications. This is something that many plans struggle with in all the different lines of business. So in MA, I cannot tell you how many plans I encounter that are using the HIC number as the primary member ID. If you're using the HIC number as the member ID, you've got problems because the HIC numbers change over time. I don't know what's going to happen in 2019 or 2020 when we go to the new HIC numbers, but at least right now, the HIC numbers incorporate more than just the person's identification. So really what's incumbent upon anybody that's trying to do population health or measure population health is that you have to have an impenetrable master patient index. This is not easy to do. I've worked on it for years. We've got it to a point where I think we've got it pretty good. It is not easy. And remember that in Medicare Advantage, you have the benefit of most members are locked in for a year, January to December. But in the exchanges and in Medicaid, there's no such lock-in. So people come and go. So as people enter and exit issuers or MCOs, a lot of times those member IDs, don't follow them. And what you end up with when they come back in the plan is now you end up with two records or two people, in quotes, with each with partial data. So there's really nothing more important than being able to do patient identification. And a lot of plans think they know how to do it, and then when you really get into the data, you find, or we find, that there are serious deficiencies. By the same token, provider identification is actually harder because of the many relationships between providers and groups and hospitals and so forth. But again, if you don't have accurate NPIs and taxonomy, with the provider taxonomy, now it's true that the NPI taxonomy crosswalks are public data. So you can get those, and if you have an NPI, you can get the taxonomy. The complexity of that is that providers can have multiple taxonomies assigned to a particular NPI, and providers have multiple NPIs. They're officially only supposed to have 2, but in practice they have many, many more than 2. So it really is very, very, it's complicated, but if you really can't assure yourself that you know who all your providers are, that you have their discrete NPIs and the personal NPI as opposed to the organizational one, and the proper taxonomy code, then you're going to get a whole bunch of really spurious results from any population health platform. The other issue is inpatient episodes. I regularly see severe deficiencies in inpatient episodes, and actually one of the quick checks that I do of plan data or provider group data is I look at their inpatient data and I look if the place of service code is populated, and if it is populated, I know that there's lots of problems because there is no such thing as a place of service code in 837I or UB04 claims. It's not defined, but there are data processing operations that impute it, and that just messes everything up. You need to use the bill type field for your institutional services. But plans often struggle with the application of void and replace claims, making sure that they're linked back to the proper or original claim. Since inpatient claims often come in on multiple claims, or inpatient episodes are often documented on multiple claims, a lot of times those claims do not have identical admit and discharge dates, and making sure that that happens is really vital for doing anything, because if you don't have consistent admission and discharge dates within an inpatient episode, you will create phantom episodes, and that has an effect just on the quality side. The readmission measure, the NCQA readmission measure is very, very date sensitive. If you get the dates wrong, you will get the wrong readmission rate, and it will probably be too high. So again, that's really a crucial data element. One of the things that we do is we build a confinement table. We aggregate the inpatient facility data up to the level of the confinement, and there's a methodology for doing it. It's, again, not simple to do, but it can be done. And there's a reason, why we, create this table, and as the slide indicates. And one has to deal with the fact that there's all different kinds of inpatient admissions. One of the things that's really important to understand is that in Medicare Advantage for risk adjustment, observation stays, which are increasingly common, are not included for the diagnoses from observation stays are not included in the risk adjustment models. So one has to be very, very cognizant of all the different types of inpatient confinements and deal with them appropriately. Unit costs of care, as most of us know, capitated claims often don't have paid and allowed amounts. Sometimes they are, the plans will reprice them. And even if fee-for-service claims often have inconsistencies in average unit price for relatively discrete services. And I admit that repricing at the service level is very, very difficult. So actually, this is where you can use the Health Partners total cost of care. And I'm not going to go into it any deeper than this, just by virtue of time. But the total cost of care algorithm actually has a pricer in it. It also relies on ACGs for risk adjustment, so that's part of the reason why why we're talking about it. But this is a very, very brief description of the algorithm. It's National Quality Forum endorsed, and it does a lot of things, but you can also quote take it apart and use it for repricing of unit costs. On the subject of diagnosis codes, this is interesting. You would think that we've been, obviously, if you go back in time to the early 2000s, people, when risk adjustment was on the horizon, because Medicare Advantage risk adjustment started in 2004, and a handful of state Medicaid programs were already doing risk adjustment starting in around 1997. You would think that after 15 or almost 20 years in some cases, that plans would have diagnosis codes, the collection and management of diagnosis codes figured out. I wish that were true. What's really, I guess, disheartening, is probably the best way to say it, is that even though the HIPAA 5010 standards have been the law of the land since January of 2012, which is now going on 6 years, we see a lot of plans that are not HIPAA compliant, that their transactions are not HIPAA compliant. And to be specific, what a lot of times we see is the plan is compliant at the EDI gateway, meaning that at the EDI gateway, when the data is coming in, they accept 12 diagnoses on the professional 837P transactions, and up to 25 diagnoses on the institutional 837I transactions. And I guess I got those backwards. I'm sorry. But then oftentimes what happens is once the data passes through the EDI gateway, it is then shoehorned into legacy systems that are not HIPAA compatible and HIPAA compliant, and all kinds of bad things start happening. Diagnoses start getting lost because you get systems where they only take 4 diagnoses, some take 8, so you end up with splitting of claims, to be able to get all the diagnoses through, and it really is a mess out there. And that's true in large plans and small plans as well. We see this a lot. And this is something that, again, if you're going to do population health, legacy systems aren't going to work because they were never designed to ensure the integrity of the data that's needed for population health. So what if you haven't mastered encounter data? Well, as I said earlier, focus on data reconciliation, tracking that every service along the pipeline is getting into the data. Ensure that legacy systems are 5010 compliant and not just at the EDI gateway, as I said a moment ago. And this is circling back, so the ACG system has a number of very, very useful data integrity tools built into it. So you can do a lot of stuff, as does the Health Partners Total Cost of Care. We use those for data integrity because there's a lot of very valuable metrics that will really help us see when we're missing data and so forth. In conclusion, I think we're right at 1 o'clock. Oh, I'm sorry, we're a couple minutes past 1 o'clock Mountain Time. I think the ACG system represents a very, very useful system for population health. While it's not completely open source, but between the copious documentation and the published manuscripts, one can understand how the system works. There's really a lot of transparency, not 100% transparency, but there's a lot of transparency. And as I said earlier, you can customize the system to various locales by way of local weights. We haven't done webinars for about 9 months, but we're going to try really, really hard to stay to our monthly schedule starting today. Our next webinar will be on Thursday, October 19th, and we're going to talk about quality improvement in Medicare and Medicaid managed care plans. You can always go to our website. The URL is there, and that's how you register for our webinars or off of our emails. Both work the same way. Also, although it's not on the slide, but very, very soon we will be making all of our webinars available on demand. So after we do them, like today when we record these, we will then be posting them on our website, and people who did not get to see the webinar, see and hear the webinar, or people that want to hear it again, will be able to access it on demand. The technology is there, and we're in the final stages of getting it implemented and tested. If you have any questions, you can always reach me or Mark McCowan, our our Senior VP of Business Development. Mark, even if it's not a business development related question, certainly Mark can triage it and get it to the right person here at Mile High. If it's me, then I'll be more than happy to answer it. But there are other people that we might get answers for. So thank you very much. I'm sorry we ran over, but thank you very much for participating. And for me, it's kind of glad to be back. So we'll look forward to seeing you on Thursday, October 19th. Have a good day.